Okay, so good evening and welcome to our first Learn and Share conference call of 2020. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for this evening is shared decision-making for improved epilepsy care, and we're pleased to have as our speaker Bev Crider, who's founder and CEO of Patient and Family Partnerships. So good evening and thanks for joining us.
Thanks for having me.
So can you briefly introduce yourself, talk a little bit about the work that you do, and describe your experience with this topic?
Sure. And again, thank you for inviting me to join you and talk about one of my very favorite subjects in the whole wide world. So I got into this world of healthcare by way of my daughter, Meredith, who was born with a number of neurological disorders, epilepsy being one of them. She had hydrocephalus, Dandy Walker syndrome. Joe was kind of felt a little bit outside of the norm, and so it motivated me to become her advocate and get very involved in her care. And what was clear to me early on was that as Meredith's mom, there were important things that I knew about her that the healthcare providers did not know that they needed to know in order to make the best plans for her and for her to have the best possible outcomes. So partway into this journey, I learned about this thing called patient and family-centered care. And we're talking about shared decision-making tonight. That's another word. There is lots of different language to describe the basic concept, but it basically it's about working together as a team to achieve the best outcome for patients and for the families and for providers as well, I would say. So first and foremost, I'm Meredith's mom. Meredith passed away about 2.5 years ago, but she and I continue to do this work. Anything that I know that has any relevance to anybody at all on the planet, I only know because I'm her mom. And that circumstance allowed me to do some groundbreaking and fun and exciting work in the arena of patient and family-centered care. I created what now is called the Family Center for Children with Special Health Care Needs within the Children's Special Health Care Services program about 30 years ago. Then I went to work in a managed care setting, creating partnerships between the people who were authorizing care and the people who were receiving care so that we made sure that the services and care that we were authorizing was appropriate and was consistent with what the patient needed and what the family wanted. And then for about 12 years, I was the director of patient and family-centered care at the Children's Hospital of Michigan. Again, having an opportunity to kind of be a bridge between the provider community and the family community to work together in order to achieve best outcomes and kind of facilitate good, productive conversation. So my experience with the topic is both professional and also deeply personal.
Okay, well, thank you for sharing that. And can you start by briefly describing the whole concept of shared decision-making? And we'll go into more detail on that later in the discussion, but just kind of give us an overview of what that refers to.
Sure. So when I think of shared decision-making, I think of healthcare providers, patients, and families working together, again, for the best outcome for the patient. That those partners, it's partnership, it's collaboration. There's, lots of different language to describe what I think is the same thing.
Right.
Ideally, it's based on evidence-based practice, as well as the patient and family values, their preferences, and the knowledge that they alone possess about what will and won't work within their family construct or for themselves or for their children.
Great. Okay, so how has the nature of the doctor-patient relationship changed over the years, and what are some of the factors that have contributed to that evolution?
Well, when you think back years ago, healthcare was very system-centered. So it was set up to meet the needs of the institution or the people who worked in the institution. So I don't know if anybody in this call is old enough to remember when physicians used to have Wednesdays off, because that was the day they all went golfing. And so, if you were a patient or a family member and the only day that you had that you could make appointments was on a Wednesday, you just were kind of out of luck. It also, so hours of care, everything was driven around meeting the needs of the system or the provider. And it was phenomenally inefficient and ineffective. And, somewhere around the mid-'80s, well, the idea of patient and family-centered care was first introduced in nursing literature in the 1950s with this, crazy idea that healthcare should be built around the needs, priorities, and values of patients and families. It was referred to as the Copernican Revolution. Some of you may remember from your grade school social studies classes that Copernicus was the scientist back in, I think it was the 16th century, who dared to suggest that the Earth was not the center of this universe, but rather the sun was the universe and all the planets revolved around the sun. He got in big trouble for that idea and was only recently, within the last 20 or 30 years, I think the Catholic Church finally said, okay, he was right. But it's this idea of switching the point of focus from everything revolving around the healthcare system to really revolving around patients and families. In the 1980s, Surgeon General Coop put forth a call to action to states who were receiving funds. They're called Title V dollars, Title V funds, the programs for children with special health care needs, maternal and child health programs, those sorts of things. And he challenged the states to create systems of care that were family-centered, coordinated, and culturally competent. A few years following that call to action, that language was actually included in the federal legislation that authorized the funding for these programs. And so states were placed in a position where they had to develop a system that was more family-centered in order to receive the funding that they were relying on. So that was a really important policy decision that drove some of the early thinking about patient and family-centered care. It began primarily in pediatrics, and once we were providing care in this way for patients who were covered by government-funded health care, it was pretty easy to, cast a wider net to all patients and families. Probably, though, the biggest boost that this new approach got came around with the publication of a document called Crossing the Quality Chasm. And it was looking at quality and safety in healthcare. And the document, the report that went to Congress, identified 5 key strategies for improving safety quality. There was this 100 Million Lives effort to reduce medical errors, make healthcare of higher quality and much safer. And one of the key components to achieving that goal was identified as care becoming more patient-centered. So the healthcare world came to understand that working with patients and families in a more collaborative way wasn't just a nice thing to do. There were some financial incentives for it, and it also resulted in better care and better outcomes. And it's just kind of taken off since then.
Right.
Used to be found almost exclusively in pediatrics, and now you see it everywhere in healthcare.
Right. And there's also been kind of a shift in just physician attitudes as well, and this shift from a sort of a paternalistic approach of I'm the expert, I know what should be done, to a more collaborative approach? Was there anything in particular that drove that transition?
I'm not aware of a specific thing that drove that, but you're absolutely right. I think that once physicians began, kind of tried it out, and in my experience, for example, at Children's Hospital, when I first went there in 2004, some of the physicians who had been in practice much longer were of the attitude that, look, this is how I've been practicing my whole career, and everyone's happy with it. I don't have any problems. I don't want to change. And, it's tough to change the behaviors of someone who says quite explicitly, I don't want to change. But once you were able to demonstrate the efficacy and to demonstrate the value and some of the other side benefits, then, there's one physician that comes to mind who is probably the most entrenched, and no way I'm not going down that path, who is now, one of the biggest champions of patient and family-centered care. So
great.
I think, it's a learning curve.
Yeah. And that leads perfectly into the next question, which is, what is some of the evidence or some of the research that supports the idea that shared decision making results in actual better health outcomes?
Excuse me. I'm sorry. For those of you who came on the call late, I have a cold, so I'm going to ask you to forgive me when I cough. So we know a lot of this information anecdotally. A lot of it comes from examples that people are able to cite that, I tried this and it worked, and it was really, resulted in a better outcome for the patient. The patient was happier. I had a better day. If you can think about yourself and how you spend your typical day, if you're able to work together in a pleasant way with some, and that, they're not always fun conversations, but in a productive way, I should say, and come out with a success, that's really, really rewarding. So there's some of that. There is not a ton of empirical evidence, although the Agency for Healthcare Quality, or Healthcare Research and Quality, just yesterday released a draft report on strategies for patient, family, and caregiver engagement. And they were looking at, I'm guessing at these numbers, but something like 150 studies that were focused on patients who had a specific chronic disease, so things like diabetes management, seizure management, those sorts of things. Then they also looked at a smaller number because those were the studies that were out there, of impacts from patient and family-centered or shared decision-making at the institutional level within a hospital or a hospital system. And there was only one example from the community level that was focusing on policy. So I think there's an opportunity where people are out there doing it. I was in a meeting in Washington on Monday, and people who are on board with shared decision making are busy doing the work and not so much on collecting the data and doing the research. So that's really an area of tremendous opportunity for us, especially, I think, in the area of population health, which is more widespread community health initiatives, and policy setting. I will tell you, as Meredith's mother, I am madly in love with public policy, because that's what you can hang your hat on at the end of the day, whether it be education, healthcare, or what have you. If you have good, solid policy that supports best practice in terms of how health, the Surgeon General's call to action, for example, on patient and family-centered care, and then embedding that language in the legislation was tremendously powerful to the advocates to be able to say, we need to create a mechanism for patients and families to be able to inform us about what's working for them, what's not working for them.
Right.
So, a hugely growing body of research, but much, much, much more work to do.
Okay, great. So, honoring patient preferences is a key component of shared decision-making, and some people, prefer to play a limited role in decision-making and kind of place their trust in the physician to make the appropriate decision for them. So what are your thoughts on how the principles of shared decision-making apply to these individuals who, are more comfortable with the physician, making the decisions for them?
Sure. It's a really good point, Russ, and I'm glad that you asked that question. Patient and family-centered care, or shared decision-making, or collaboration is about offering options. And, you're absolutely correct that not everybody wants to jump in and make those decisions, at least not at the beginning. I'm thinking about a woman that I know who's a very well-respected patient and family leader from the San Francisco area, and her child was born with a very serious liver function disorder and born very prematurely. And she said, in those early years, I just wanted you to tell me, when should I come and pick her up and bring her back home? Because this is over my head. It's overwhelming. I can't absorb it all. I don't want to know. And now she's guiding other families throughout Stanford Children's Hospital, to become more active and engaged. So you have to approach people where they're at, and if somebody doesn't really want to be that involved, we need to respect that. But I think we also need to help them understand another way. So number one is issuing the invitation and saying things like, I know a lot about epilepsy, but you know a lot about Deborah. So tell me what I need to know about Deborah in order to best help manage her seizures, for example. At that because a lot of families or patients they're not sure what their role is. So you have to help lead them there and give some anticipatory guidance and let them see why their role is important, what they bring to the table to say, I only see Johnny for 10 minutes every 3 months, and you see him every day. So your observations are really important. And if you could jot down some of those observations or take some videos or share that information with me, it's going to help me to work with you to come up with the best possible plan. So I think you can't bash them over the head with it, but you can't assume that anybody doesn't want to be involved. You have to have the conversation.
Right. Okay, so the SHARE approach is a specific model for shared decision-making that was developed by the Agency for Healthcare Research and Quality, or AHRQ. It's designed kind of as more of as a tool for healthcare providers, but the basic principles can also be helpful for patients and families to understand. So can you review kind of the different components of the SHARE approach from the patient and family perspective, and maybe give some examples or two to illustrate each step in the process?
Yes, absolutely. And I think I love the SHARE tool, and I think that this is a great example of how healthcare providers can have a conversation with patients and families and help them understand what the possibilities could be about shared decision-making and working together. So SHARE is an acronym. Healthcare loves acronyms, and we want to have little buzzwords for just about everything. But the S stands for seek your patient's participation. So that's issuing the invitation, saying to the patient, I want to be a part of this. And on the flip side of that, from the patient and family side, I think, to say, this is my life, this is my child's life. I want to be an active participant, so I want to work with you. Will you be my partner? And when you ask somebody that question, will you be my partner? It's a powerful question. I remember a time I had a colleague that he had done something that I was really, really upset about. He had, used my work in a grant and included me without talking to me, included in the application without discussing it with me, and I was really upset by that. And he called me and said, he apologized and said, can we agree to work together? And that was like, how do you say no to that, right? And then having articulated, yes, I will agree to be your partner, it stays with you. It stays top of mind, and you have to say, okay, I agreed I was going to be a partner with this person, so I'm going to go ahead and do that. The H stands for help your patient explore and compare treatment options. And so I think where patients and families can, their role in helping to explore and compare treatment options is to, talk about what has been tried in the past, perhaps, or what you think is going to work, or, there might be a pretty common approach, but it's not going to work in your circumstance for very individualized reasons. So one example of that might be when I worked in managed care. All the members of this managed care plan were children who had special health care needs. And oftentimes we would get orders for equipment, a wheelchair or a walker or what have you, to be used at home. And all too often we would authorize that. We would, the equipment would be ordered, it would get delivered, and we would find out from the family after the fact that it didn't work, it didn't fit in their doorways, or it just, it wasn't functional in their environment. And so we started then requiring that the durable medical equipment providers do a home visit with the family first, to go into the home, to see where the equipment was going to be used, to talk to the family about how they were going to use the equipment, what they needed to do with it, so that we got the very best, not necessarily the very best wheelchair, but the wheelchair that was going to be best for that child and would be functional for them. So you can have these conversations. Step 3 is to assess your patient's values and preferences. And I think that from the patient and family side is to talk about your values and your preferences, to discuss things like, well, I'm struggling to come up with an example, but find out what matters most to the patient and family, because there are almost always more than one approach to solving a problem in healthcare. And if you have an open and honest discussion about that, what that is, you're going to have a better outcome on that.
Right, just to jump in, an example that I have heard a lot from families and individuals is, a preference, or is a lot of people will say, tell their doctor, I'm more interested in holistic approaches, or I'm more interested in natural approaches, or lifestyle approaches, as opposed to immediately going to medication. So it doesn't mean they're against medication, but it may mean that they just want to consider other options before trying medication. So that type of thing is, a good example that comes up a lot in people I've talked with.
That's a great example. That's perfect. And you see a lot of that. I think people are much more tuned into those approaches to healthcare, and it doesn't mean it's a either or. Maybe it's a this and.
Right.
Kind of situation. That's great. Thank you, Russ. So the R stands stands for reach a decision with your patient and family, decide together on the best option, and arrange for a follow-up appointment. So, deciding together on the best option is deciding together on the best option. And so from the family's perspective, it's important to be an active part of that conversation and to ask, well, what are all the choices? And agreeing upon the one that's going to work best. I mean, there might be an approach that, is a great approach, but it's just not going to work in the context of your family and your lifestyle. And so families need to be really open about that and say, I hear what you're saying, but, I work from this time to this time, and I'm not able to take these meds on that time schedule, or I don't have access to a pharmacy, or whatever it might be. But to really talk about those things, because, clinicians are really good problem solvers, and they've usually got people in their offices that can help work those things out. And if you're not ready to make a decision, it's fine to say, I think I need a little bit more time. This is a really big decision. Is it safe to wait a little while on that? And just be really open and transparent about those things. The E in share is evaluate your patient's decision. And I would say evaluate the joint decision. I think that, one of the beauties of shared decision-making is if a decision to take a certain approach is made collaboratively, then you're much more likely to follow through with that, right? Because you said, we talked about it, and I see now what the benefit is in this and how it's going to, what some of the ways that it might affect my life and the trade-offs. But you need to go back and evaluate it and make sure that what you thought was going to happen as a result of this choice is actually what's happening, and stay in touch, and taking a little trial period and doing a follow-up. So that's
right.
That's sure.
Yeah, and this it may not explicitly say it in the model itself, but this applies not only to treatments but also to diagnosis and other things like, should I have this expensive test done? Should I get a second opinion? Those types of decisions, as well as just treatment decisions. Right.
Thank you. You're right. Yeah, there's so many decisions to be made. It's overwhelming, and to try and make them all in one, short appointment can be a little overwhelming.
Right. So what do you see as some of the common barriers to shared decision-making, both for the healthcare provider and the patient and family?
Well, I think the first thing that pops out to me is time. People are, at least from the healthcare provider side of it, in my work at the hospital, providers are under the gun to get a lot of work done in a short amount of time. They have to use their time really, really efficiently, which is why it's so important to have the dialogue, because if people aren't speaking up, you might think, okay, that's taken care of, and move forward without having the full picture. And that's not really shared decision-making if you don't have that open and honest. The early literature around collaboration and information sharing talked about complete and unbiased sharing information. As Meredith's mom, I was an information junkie. Anything you knew about or thought you knew about my child, I needed to know that information so that I could evaluate it and make those decisions. So information sharing, respect for time, those sorts of things, I think are really important. I think, at the end of the day, it all boils down to communication. And it could be communication about what's been happening with the patient. It could be information about, best clinical practice, new evidence that's out. It could be information about what insurances are covering or not covering. Those are important things to know. And those conversations take a little bit of time to work through. So anything that facilitates good communication, I think, it also facilitates shared decision-making.
Right. So there are probably hundreds or even thousands of versions of patient Bill of Rights that have been created over the years, and some of which also appropriately include patient responsibilities. Are there any of those that stand out to you as being particularly helpful? And what are some of the common rights or responsibilities listed that perhaps aren't covered under the SHARE approach?
Well, to be honest with you, I may have a somewhat unpopular view of Patient Bill of Rights. I have personally been involved in writing and revising those things in, every setting I ever worked in. So I'm really familiar with it. And it always was sort of ironic to me that before I walk into your institution or before I walk into your office or before I sign up for your program, my Bill of Rights is, outlined in the Constitution of the United States. And so I have a right to free speech and I have a right to, a lot of different things. And I have autonomy and responsibility for myself and for my child. So when I see things written in Patient Bill of Rights that say things like, you have the right to ask questions. Well, no kidding, I have the right to ask questions. This is my life. This is my child's life. It's not that I have a right to ask questions. I have a need to have information. So that one is, I'm a little bit of an outlier on that one, Russ. I think the language in and of itself is a little preposterous. Now,
yeah, so,
having said that,
go ahead.
Well, I think that there are some things that need to be articulated to help us understand one another. So when we walk into a healthcare environment, what most people don't understand is it's an entirely a culture unto itself. So there are, one of my friends on Facebook had a doctor's appointment this week, and she posted a picture of a sign that was displayed in the waiting room, and it said, notify the receptionist if you have not been worked up by the nurse within 10 minutes. She thought it was ridiculous. So what does worked up mean? And what does, it was just kind of like so open for interpretation. Mm-hmm. But that to the people in the office, that language made total sense. They knew what that meant. They meant that the patient had been triaged, that you found out, what's the reason for the visit and all that kind of stuff. So they were talking two different languages there. So I think that any tool that helps understand what the expectations are. So here's what you can expect from us. Here's what we need from you. Everybody is expected to treat one another with respect and dignity. Everybody. Not just the patients have to be nice to the healthcare staff, not just the healthcare staff has to be nice to the patients. We all have to be respectful. This is a healthcare setting. We're here about healing. We're not here about anything else. And to emphasize the importance of sharing information. Again, that's a two-way street. It's important for me to tell you that, my child had this reaction to Klonopin when we tried it, so we don't want to go there again. And it's your responsibility as a healthcare provider to tell me, what's the newest research on Klonopin, or what are the newer drugs that are available that can have the effect that we're trying to achieve. So I lean more towards articulating shared expectations rather than here are your rights, because I think I already have rights when I walk in the door.
Right. And not to mention that half of these patient bill of rights are buried somewhere deep on the website, not even displayed, and yeah.
Yeah, and if you go into a hospital, the hospital is required to give them to you in writing, but they're not required to write them in a way that's easily understandable.
Right.
And again, you're going into a hospital in this instance. That's not top of mind. Top of mind is you or your family member has a healthcare problem that requires treatment, not reading through 6,000 pieces of paper.
Right. So you alluded to communication earlier. So clearly, effective communication is at the core of shared decision making. So let's start by discussing some common mistakes and some key recommendations for clinicians when it comes to communicating with patients and families.
Sure. I had some people over to my house this weekend, and I was telling the person on my right that I was going to be talking about shared decision making, and sitting to my left was my friend who's a really great rheumatologist. And my friend said, "Oh, shared decision making, what is that? And why do you need that?" So I explained what it's about, and I said, really, shared decision making is what involves the behaviors that most of us should have known in grade school about, treating with people with respect and calling them by name and those sorts of things. And for some people it's intuitive, and for others it's not. But I do have a few real specific ideas about that. The first one is for clinicians, is to call the patient and their family members by name. It is my pet peeve and the pet peeve of a lot of people to be called mom, or it's kind of like, I don't want to get too political, but back in the 70s, around the time of the Equal Rights Amendment movement, women were referred to as honey or sweetie. It just, all that does is say, you're not important. When you call me mom, that says that you're not important enough for me to remember your name. You're here. You're kind of superfluous to the process. I'm the important person here. I'm Dr. Smith. You're just whatever label you happen to have. When we did some research at Children's Hospital, I would round on patients so I'd take some questions up to the unit, and I would ask a sample of patients, and I would ask a sample of the staff. And one of the questions that I always asked was, how well does staff meet your emotional needs? And the staff would always say, oh, gosh, we don't do a very good job of that. We don't have time. We don't have a social worker on our team. We don't have a psychologist available to us, and we really would like to get a lot of information to people and support them. And so they rated it very low. But when I asked the families, how well staff meet your emotional needs, they rated it very, very high. And I would say, well, tell me why you're rating that high. They call me by name. One mom was in tears because the unit manager saw her son outside of the room, outside the unit, kind of in a different area, and remembered his name and called him by name. And she said, I know she really cares about him because she called him Matthew. And it just was, I cannot overemphasize the importance of that. One of our family advisors said it really well. She said, when you call me mom, that lets me know that I'm seen as the person who's responsible for making sure that, the teeth are brushed and he's wearing clean pajamas and the homework is done. But when you ask me my name and then you use it, that tells me that I'm a respected member of this team and you're really listening to what I have to say. And it opens the door for me to have more and better conversations with you and share my observations about my child. So that is like my number one thing. I also think that it's important to use what's called plain language. So when I'm working with physicians, I say, imagine that you're explaining this you're sitting in your living room at home explaining this to your grandmother or to your son or daughter. My son is way smarter than me, but I would use very plain language. I wouldn't use a lot of technical terms. I wouldn't use a lot of, multi-syllable words. I would say, this is basically what it boils down to. And the smartest people are able to explain things in the simplest way. And so to get out of that medical ease that kind of, promotes that us-them dynamic is really, really important. And you can't do that all the time. So, there are some things that need to be conveyed that don't have simple language to describe it, but to the maximum extent possible, that's pretty important.
Right, and just to interject there, it made me think about, there an exception to that, like you just mentioned, there are things that do have, proper terminology should be used. And,
right.
I've heard many people say that they've been told by their doctor, like, well, you have both kinds of seizures. You have the big ones and the little ones, and kind of, we're not talking about dumbing down the language, so to speak,
no.
but we're talking about plain language that is as simple as it can be, and and you can certainly use medical terms when appropriate, as long as you're sure that the person understands what they are. So,
or you're prepared to explain what it is.
Yeah, exactly.
You have a petty seizure. That's a small seizure. We don't worry about those as much. This is a grand mal seizure. That was a big seizure. We worry about that a lot. Mm-hmm. Those kinds of explanations are important. It's also really important to ask about patient goals. Now, the patient's goal might not be the goal that the clinician has, but it's important to understand what those goals are so that you can work around that. You're probably familiar with this book, Russ, and many of the people on the call. The spirit catches you and then you fall down.
Yeah.
Yeah. So that's a story of a family who immigrated to Merced, California from Laos. And the Laotian culture believes that, so their explanation for a seizure is that this is a blessing from the gods. And the seizure is evidence of this particular spirit entering the body of the person, and so hence the title, the spirit catches you, and then you fall down. And so to them, this is a tremendous blessing. They have absolutely zero interest in stopping the seizures because they think this means that their child, that culture supports the belief that, the child or the individual is, has had a special divine blessing. And so if you know that the patient goal is not to stop seizures, well, then that's a whole other conversation that needs to happen. But if you don't know that, and what this book illustrates is how the healthcare world was, barreling down this path of controlling seizures in the family, it wasn't important to them. Lots and lots of, it's a great book. If you haven't read it, I recommend it. It's a case study. It actually happens, but it's just a really good illustration about how both parties having a totally different objective in mind really led to some unfortunate outcomes.
Right, and it also, brings up the cultural sensitivity and understanding cultural background and preferences is also very important. So
right, and you need to ask, because just because I'm Laotian doesn't mean that I share that belief system. So you need to have a conversation, and what's important to you here. Maybe it's what we had a. Russ, you've already heard this story, but we're a patient at Children's who, she was 17. She had an infection. The goal of the hospital was to make sure that infection was totally and completely eradicated, which is a good goal. The goal of the 17-year-old was to go to her senior winter dance that night. She had the dress, she had the hair appointment, she had the nail appointment, she had the date, she had all that. And it was kind of, kind of on the edge of, do we have the last study in? Is it okay to discharge or not? But once we learned that what the patient wanted was to go to the dance for her senior year, we were able to, speed up the studies, get another, run another couple of labs, make sure that it was really safe, and get her out of there so she could go to the winter dance. And she sent us some beautiful pictures of her in her dress, and it was wonderful. But if we hadn't asked what her goal was, she'd missed that dance because we would have erred on the side of caution.
Right. So what are some recommendations for patients and caregivers in terms of communicating effectively with providers?
Well, I would say don't be shy. Be always respectful, but don't be shy. And if you have a question, ask it. And you have information that you think is important, share it. There are a lot of different ways to do that. Some people I know keep a written summary, kind of like some people call it a medical resume. Here's the history. Here's everything that's happened, because a lot of us have a pretty complicated history, and to try and remember and verbalize all of that. There's lots of opportunities to miss things, but and I think I can tell you that based on my work in healthcare, patients who come forward with that are the ones that, they're very much appreciated. Nobody ever says, "Oh my gosh, she gave me this, whole long 3-page report. What am I supposed to do with that?" Nobody ever says that. They say, "Oh my gosh, I got this really comprehensive report. This is going to be so helpful." And be clear about what your goals are, and be open to listening to maybe some modification of those goals, or different ways of getting at those goals. Another thing that as Meredith's mom, that was really important for us was I and her nurses started videotaping when we thought she was having a seizure. And so it's really helpful to go into the doctor's office and say, this is what she did, this is when it happened, this is what precipitated, this is how she was afterwards. That was really, really, really helpful. There's a special project on children with epilepsy that Russ and I both participate on, and one of the patient and family advisors, her son's seizures happened at unusual times, and they weren't captured through some of the typical studies, so she started taking videotapes of him, and it totally changed the course of his treatment. So, that's really important. Diaries, record keeping tools. I know there's a lot of new technology to do seizure tracking. I'm not as familiar with that maybe as you might be, Russ.
Sure, yeah. There's seizuretracker.com. There's my seizure diary, which is through the Epilepsy Foundation, through the national office. So there's many different online tools, and then some people are much more comfortable with just a journal or a calendar or some paper-based system for tracking. But certainly at the bare minimum, counting how many seizures you're having and when they're taking place, and if possible, getting some additional information on what happened before, what happened during, what happened after. Are there potential triggers? Are we noticing any kind of patterns? Was there a warning beforehand? All of that information is great data for the epileptologist or neurologist or pediatrician. And so, just finding something that works for you, that you can use conveniently and relatively accurately, and providing that. And I definitely reiterate what you said about the videotaping. Now with smartphones, that's that much easier to be able to record seizures, and that can make a huge difference, being able to see it with their own eyes rather than relying only on your description, which can maybe skip over important elements that or maybe you didn't notice a certain thing when you're telling them, and that can completely change the diagnosis or treatment decisions. So,
right,
yeah.
Extremely helpful.
Okay, so one healthcare decision that often needs to be made at some point is whether to switch providers or seek a second opinion. So sometimes patients may be reluctant to seek a second opinion because they don't want to offend their current provider, or in other cases, some people may have unrealistic expectations regarding how easy it is to reach their desired health outcomes and how quickly that can occur. And then may end up sort of bouncing from provider to provider without giving anyone a reasonable chance to make progress. So can you talk a bit about how patients should approach decisions about second opinions and or switching providers?
Sure. Well, seeking a second opinion and switching providers are two very, very different things.
Right.
And I would say, by all means, if you think that you would like to have a second opinion, ask for a second opinion. I have any provider who, I don't want to say good or bad, but I know, good provider, they're going to be happy for that. They're going to facilitate it. They want you to have the right information. They might say, well, maybe somebody else can see something that I'm not seeing. That's a great idea. Let's do that. Let's get some help on board here. And there's absolutely nothing at all wrong with that. Even if somebody were going to be offended by that, you as a patient or family member, you have to follow your gut. And so if your gut tells you, there's something else out there, I wonder if somebody else has seen this, and if somebody else has more information than I have, then that's not just your right. Here I go with rights again, but, I think it's you're kind of obligated to do that, to unturn any stone that you think needs to be overturned to find the best information to provide the best possible care. So I'm all about second opinions, and, they take a little bit of time, because what you want is for the current provider to share the background and history with finding who the second opinion is going to be. You want them to be able to have an exchange and share information, so the second person kind of goes into it with a little bit of background. So it might not happen overnight, but absolutely do that. Absolutely do that. If you're going to change providers, I think you need to say, I'm going to change providers. I appreciate what you've done up to this point. I think we might do better somewhere else, because that way you can facilitate the transfer of records and studies and whatnot. And I think it's just a respectful thing to do. Nobody likes to be, just to have somebody drop off the face of the earth with no explanation. So I think it's the right and responsible thing to do. But you've got to be comfortable with who you're getting your care from. And if there's another place that is going to work better for you, doesn't mean that first provider is a bad provider. It just means somebody else is a better match for you. Right, absolutely. I wouldn't worry about it. Yeah.
Yeah, and there are also some red flags early on in a doctor-patient relationship where if you ever feel like you are not being respected, if you ever feel like you are not being listened to, if you feel like your concerns are being glossed over or dismissed, those are pretty key red flags early on if you're noticing that, and I don't think people should hesitate to find someone else if you don't have those foundational aspects of a doctor-patient relationship evident early on.
Absolutely.
So, yeah.
Well, early on or even later on.
Yeah, right.
One of the families that I worked with said, you're either on Team Peter or you're not on the team. So here's where we're going. We're going towards health. We're going towards, maximizing potential. If that's not if you're not on that team, then you need to not be on the team. And there's absolutely not one thing wrong with that.
Right.
just be respectful.
Yep. So epilepsy can be particularly challenging in terms of shared decision-making because so many decisions depend on accurate reporting of seizures, side effects, and medication adherence. And all of those can be notoriously difficult to track or describe. So, for example, if someone underreports how often they miss a dose of medication, they may actually have their medication dosage increased when instead they should be given tips on how to improve adherence. Or if someone underreports how many seizures they've had, either because they didn't recognize them at the time or maybe because they're afraid that that might result in additional restrictions, the doctor may maintain the status quo in terms of treatment when in fact treatment adjustments are needed. So can you talk just a little bit about how some of the challenges and some tips and tools that can be used to help patients and families accurately track and report necessary health information?
Well, I think you identified some great tracking tools that are available online, and some of the the old school pencil paper things, those work too. It's just important to share. Again, going back to the early literature about collaboration, is the complete and unbiased sharing of information. And I understand you don't want to lose your driving privileges, or you don't want your child to lose their driving privileges, but there's a reason that those rules are in place. And you have to think about what's the long-term goal. The long-term goal is optimal health, right? And it's just absolutely essential to tell the truth as you see it and share everything you know, not, well, I had one seizure last week when, you had one seizure last week at lunchtime and, several other seizures, at another time of the day. I just think that if your goal is, if you really want to do shared decision making, providers can't make good decisions without good information. They can't help you reach a shared decision if you're not sharing all of the information. And so, you just got to tell the truth.
Right.
I know it's something easier said than done, but it's critical.
Yeah, and embarrassment and shame and those types of feelings can sometimes come into play of like, oh, yeah, I've been really bad about taking my medications. I've not been on the ball with that, or I haven't been good about getting enough sleep, or I haven't been, I drank a lot of alcohol that one night, and that these types of things can make people reluctant to share that because of they feel embarrassed, they feel like they're letting the physician down sometimes, but again, if you're not sharing that is going to directly affect treatment decisions. So,
well, absolutely, and I think most people want their physician to view them favorably and to think that they're a good parent or a good patient, but everybody understands that those things happen, and you can get them really, as you said, you might get over-medicated or under-medicated if you're not open about it. The other thing is, some of these things you might be able to anticipate up front. So if you're given the recommendation is to, a certain medication schedule or a certain sleep schedule, and you've got work responsibilities and parenting responsibilities or school responsibilities that is going to make that really challenging. Say those things up front. Say, I just really don't know how I could fit one more thing into my day. I've got, I have 3 kids and they're very young, and I've got a job, and I've got this and that and the other thing. And to the extent that the provider understands that, there might be another approach that would be also effective, that would work within your lifestyle a little bit better.
Right.
Got to communicate.
Yep. So some epilepsy-related decisions are so complex that patients and families need to do additional research on their own to inform their decisions. And with the growth of the internet and health information sources have kind of grown exponentially. And the sheer amount of information can be overwhelming, and that can kind of lead to this analysis paralysis where you don't make a decision because there's too many decisions and you just kind of get frozen. There's also a lot of pseudoscience and misleading information out there. So what suggestions do you have to help patients and families evaluate the quality and reliability of information so that they can come to an effective and timely decision?
Well, I would ask the people who are in the business of knowing these things. So, for example, Epilepsy at Foundation of Michigan is a good source of information. You guys are responsible for staying on top of that and being able to say, this is what we know, and this is why we support this, and this is why we think that this may be less reliable. Likewise, within the clinical practice, generally there are nurse educators who are available, or the physician, and just say, I'm looking for more information about this. Where do you suggest that I go? In a hospital setting, a lot of hospitals have medical librarians. They are a wonderful, wonderful resource for sifting through all the stuff that's out there on the internet. You know, anybody can post anything on the internet without any kind of vetting process or credentialing or whatnot. So you want to make sure that you're going to a good source. But as a layperson, it's hard to know what those sources are. So I think go to the people whose job it is to know those things and ask them, and they're very willing to help you.
Right. So one of those sources of information are online forums. And so there's tons of online forums related to epilepsy and other health conditions. There's also direct advice from other families who've had personal experience with a particular condition or treatment. And those can definitely be valuable, but should not be the only source of information used to make decisions. So what are some pros and cons of this type of information and support that you're getting from other families and individuals?
Well, first I want to say that you just cannot possibly overestimate the value and benefit of peer support. To have the opportunity to talk to somebody who's kind of walked that walk, who understands the language, who's kind of been there, done that. There's a magic to that I've been doing peer support since 1988, and I still am not able to articulate it any better than that. It just is super important and super supportive. One of the benefits of those kinds of forums is sometimes you get some ideas about things that you hadn't heard before, things you hadn't tried, and it gives you kind of a list to think about with your provider. On the other hand, an individual experience can't be generalized to all people who have epilepsy because, you know, every patient is different. Every seizure is different. There's not a lot of, just because, person number one had this kind of seizure and that worked doesn't mean that person number two has that kind of seizure. It's going to be the same outcome. So I understand as a mom that it is really tempting to want to say, well, this works, so I want to try it, because you're just so desperate to make your child as healthy as possible and make yourself as healthy as possible. But I would use those things as ideas to discuss with your clinician and say, I understand that some people that have had success with X, Y, and Z, what do you think about this for me or for my child? I cannot tell you, so towards the end of my daughter's life, her seizures were, she was having more seizures more frequently because she was retaining CO2, and so her seizures were the result of her blood gases being off. And I can't tell you how many people told me I needed to talk to her doctors about using marijuana to control her seizures. And I'm like, I'm glad that worked for you and for your friend, but that's a total different kind of seizure. So you just need to have those conversations with the people who know your child, know you, and know epilepsy management.
Right, right. But yeah, I like how you kind of talked about it. It's a place for kind of generating or finding ideas, and then you can take those ideas and investigate them further from other sources, and then ultimately talk with your physician about it. So, okay, so there can be a tendency among clinicians who treat epilepsy to focus so much on seizure control and safety that they forget about other things that affect quality of life. So how can patients and families self-advocate for a more holistic approach to epilepsy care?
Well, going back to communication again, it's Jillian in the winter dance. What matters most to you? And, a lot of people will say, I would rather have this medical consequence and not be out of the loop. Personally, I don't like, if I had surgical procedures, I hate taking narcotics. I'd rather deal with a little pain than be foggy. And so that's what matters most to me, is to have a clear mind. And so and everybody has their own answer to that question, what matters the most, but to be clear about that and say, I can appreciate this is your goal, but my goal is, this is more important to me than that. And have a conversation.
Right.
And not to be shy about that conversation, or to say, this is what I'm doing. I'm going on this diet, and this is what I'm doing, and so tell me how that's going to fit into, the plan that we're developing here.
Right. We've talked a lot about pediatric care, and adult care is, there's a difference. Pediatric care tends to be more inclusive and collaborative in general than adult care. So how can teens with epilepsy and parents and then pediatric clinicians help support that transition to adult care in such a way that promotes the continuation of that shared decision making?
Well, I think a couple of things. I think it's really important to start early. I have a friend who used to, her son, when he was 4 years old, she'd give him his insurance card and have him check himself in at the registration desk.
4 years old, wow.
I know. Well, she knew that this was something he would be managing for the rest of his life, and she wanted him to learn how under her supervision. Mm-hmm. And so encouraging young people to ask questions, encouraging them to speak up, encouraging them to say what they think is important, and kind of coaching them along the way. On the other hand, so my friend, the rheumatologist, said if he had, one wish related to transition, it would be that he would be able to see the patient early before a crisis hits, because what happens so often is, there's a patient who has, in this case, juvenile arthritis, and they turn 18, they're no longer seen at the pediatric practice, and, 3, 4, 5 years go by. This young adult now is in a crisis, and he sees this patient who is in desperate need of help, and he knows nothing about their background. So his wish would be, come and see me early. Come and, let's talk about what's going on. Let's talk about what's been tried. Here's how we're going to communicate, and that sort of thing. I think that, and honestly, I was one of those parents too. I had a really hard time with, Meredith was 38 when she died, so we went through that, and she was not able to make her own healthcare decisions. And I liked the people in pediatrics. They were nice. I already knew him. I knew that when I called, it said, "Hi, this is Bev Crider. I'm calling about Meredith," that they would recognize that, and they knew that I was telling them accurate information when I was sharing it. And I didn't want to lose those relationships, but what I learned over time is those relationships, you make more relationships, and they're equally satisfying and equally wonderful. But you need to step out and step forward and get in there early before there's a crisis, if you can, to establish, take those summaries that you've written and take that information and say, here's who I am, or here's my history, and I need someone who's going to work together with me. Are you that person? And get them on record to say, yep, I'm going to be your partner. I'm going to be your collaborator. We're going to do shared decision-making. And do that before the crisis hits.
Right. So before we open it up for questions, do you have any closing thoughts on this topic that you'd like to share?
I would just say, to patients and families, and I would also acknowledge that if you're on this call, I'm speaking to the choir, but, don't be shy. Share the information, share it, respectfully, share it proudly, share it boldly, and seek those partnerships and ask people to say, yes, I will be your partner. Yes, we will share this decision-making. And if someone's not willing to do that, next, go on to find it, if you can, find in their provider. Or insist upon it if you're live in an area where an alternative provider is not a realistic goal for you.
Right.
This is how it's going to be.
Right. Okay, so let's go ahead and open it up for questions. And just to remind folks, I'm going to unmute all the lines now. So who would like to get us started with a question?
I can start, Russ. It's
okay.
Michelle.
Yeah.
I just wondered for something like when you have to discuss maybe seizure rescue medication, how would you suggest for the patient or the caregiver to talk about that? Go ahead, Russ.
So like you're referring to like medications that are designed to stop seizures that are prolonged or clustering.
Right.
So that's not always something that is necessarily brought up, particularly among adult providers. It's becoming more standard for children to be given a rescue medication, even if if they haven't had status epilepticus or haven't had clusters of seizures. But it's probably not something that necessarily comes up on its own if sometimes if the patient doesn't ask about it. And rescue medications can be helpful in certain circumstances if you are prone to clusters or prolonged seizures. It's something that can be used in the community by a layperson without needing to call 911 or needing to go to the ER to stop the seizure or stop the clusters. So I think it's important to ask about that if you particularly if you are in that risk category where you're having seizures that are either prolonged or where you're having one after the other, or if you have clusters, even if they're not immediately one after the other, but you have periods where you have several within a short time frame, whether a rescue medication would help with that. And right now we have a few different options. There's Diastat, which is the rectally administered one, which has been used, for a long time with children, and that's been kind of the go-to for most kids. There was recently one that was FDA approved and is now on the market called Nasolam. That's a nasally administered midazolam. So that's, probably more likely to be an option that would be palatable to adults. And there's another one that was FDA approved as well, that is intranasal diazepam, and that is not on the market yet, but that will be coming soon, and that's a similar mechanism to the Nasolam. So, yeah, I definitely think that's a question that can be asked. And it comes back to, Bev, what you were saying about just, asking the question, being upfront and letting people know, like if you've heard about another family using a rescue medication, and you can certainly say, should I be using one of these or not? So yeah, that's. Bev, did you have any thoughts on that?
I was going to say just what you said, which is ask the question, share the information. I mean, I don't know anything about seizure management, but in terms of shared decision making, have the conversation. If it's a question on your mind, you want to ask it. Otherwise, you might be worried unnecessarily about, I should have done this or shouldn't have done that.
Mm-hmm. Yeah, and there's another thing that Cindy, who's our nurse, often mentions is that there are situations, if you're living in a very rural area, for example, where it may be quite some time for the ambulance to get to. Let's say you're in the UP or something, then rescue medication can be particularly helpful in the unlikely event that you do have a prolonged seizure. Just to have it there as a preventive measure, or as a just-in-case measure, even if you've never had a prolonged seizure before. So, all right, other questions?
They also have one. I have seizures, but my grandson had 2 seizures, and they also have one for the rectal. That they gave for my grandson, just in case he have another seizure.
Right,
and I take lorazepam. Yeah, I take lorazepam. So when they see me going and I'm in a seizure mode, and they just give me lorazepam and tell me to take it.
Mm-hmm. Yeah, so there's several different types as well. Some that are sublingual or can be used buccally, where you put it between the cheek and gum and it dissolves. So there's a variety of other ones that might, and it really depends on the situation. And that's actually something on June 3rd, we're having a separate Learn and Share conference call on rescue medications for epilepsy. So it's another huge topic that we can certainly discuss more at that point. So other questions about shared decision making or doctor-patient communication or anything along those lines?
Yes, Beverly. Hi. I don't mean to, if you don't want to answer this or if this is wrong to ask, but what does your daughter die of?
She, because her underlying condition was neurological, and her brain was no longer sending the signals to her to breathe effectively. So she ended up, we put her on a ventilator. She was trach indented, and the actual cause of death was her tracheal wall perforated. But we knew that it was going to be something, but she's a gift for sure. And her initial prognosis was early infancy, and she died 5 days after her 38th birthday. So I got a lot of extra time with her that I never thought I was going to have. But it was her underlying neurological condition.
Was she around when they started the vagus nerve stimulator, or wasn't she able to get that type of machine? Up
until her her breathing issue became a problem, her seizures were very well controlled. So that's not anything we ever really needed to look at. She took some, pretty basic seizure meds, and that did the trick for her.
So a follow-up sort of question or a comment, I guess, is, one of the other things about communication, we were talking about doctor-patient communication, is the idea of risk communication, and that can be that plays an important role in deciding whether you're going to pursue a particular treatment option, whether you're going to have a particular test is the idea of risk and what are the risks associated with this. It certainly comes up with decisions as to whether to have surgery and that sort of thing.
Sure.
And I think one of the risks that sometimes isn't conveyed all the time is the risk of SUDEP, and that sudden unexpected death in epilepsy, and that's something that certainly there's been a huge shift in how that is discussed in the clinical setting. It used to be something that was only mentioned for people who were at very high risk and not really mentioned otherwise, because it was assumed that the risk was so low that patients and families didn't need to know about that. But that has shifted now because there's been so much feedback from people who have learned about this and has expressed very clearly that they want to know what their risk is. They want to know that this is a possibility and what they can do to reduce that risk. And I think that's just in general a very important thing to communicate with your healthcare team is, that the level of information that you want to receive. Like, do you want to be told only things that are, or do you want to be told of every possibility? Some people want to know everything bad that could happen, and other people just want to be, told about something if it's only a very high risk. So, do you have any thoughts on that, Bev, as to just risk communication in general and best practices regarding that, or?
Yeah, I think that I think you're right that people are able to. We can't make any assumptions, right? And people want different levels of information. I wanted to know everything, and I wanted to know this is extremely unlikely, but this is what sometimes can happen. Because then I felt like I was better prepared to manage when I needed to measure. There are other people who say, tell me just what I need to know to get, from here, point A to point B.
Right.
And so I agree with you to having those conversations about how do you want to receive information and how much of it do you want to know?
Great. We have just a couple minutes left. Any other questions? Okay, well, I think we will go ahead and wrap up the call. So, Bev, thank you so much for a really great call and such a comprehensive overview of this topic. And I think we all came away with some key lessons that we're going to use in our healthcare going forward. So. And thank you, everyone else, for participating. If you do have any further questions about this or other topics, certainly feel free to give Epilepsy Foundation a call at 1-800-377-6226 or visit our website at epilepsymichigan.org. Our next Learn and Share conference call is on March 4th from noon to 1:30. The topic is pregnancy and parenting with epilepsy. So hope anyone for whom that is a topic of interest will join us for that call. And again, thank you so much, Bev, for joining us, and thanks everyone else for being on the call.
Thanks for inviting me, Russ. I appreciate it. And thanks to all of you for hanging in there and listening.
Thank you for the information.
Thank you. Thank you so much.
You're very welcome. Have a great evening, everyone.
All right. Bye-bye.